So guys, the reason I just wanted to have a chat was there's been some recent evidence that's come out more or less this year into the use of steroids in severe sepsis. There's also been quite compelling evidence for the use of steroids in community-acquired pneumonia, which I think has been previously discussed in one of these meetings a couple of weeks ago. So I won't go into that right now. But as I said, we'll probably just have a quick look at what's come out in terms of their use in severe sepsis. So we'll look at our current use of steroids and where that kind of comes from. And we'll look at the new evidence for the use of steroids in sepsis. And just have a brief look at the use of combined steroid therapy. So that's a new thing that seems to be in vogue for research at the moment. And what I mean by that is a combination of a mineralocorticoid and a glucocorticoid. And just a bit of a look at why that might be useful from a physiological point of view, and why that's currently being looked into. Oops. There you go. So if we look at the current evidence for the use of steroids in severe sepsis, now that all comes from the Surviving Sepsis Guidelines, initially published in 2016. And if you look at the guidelines and you go down, it says that it suggests giving IV hydrocortisones to patients in refractory shock. And what that means is shock despite adequate fluid resuscitation and vasopressor therapy. And it doesn't necessarily give a definition for what adequate fluid resuscitation means, but I guess that's just on a case-by-case basis. And they advise giving a dose of 200 milligrams daily. Now, that originally was listed as weak evidence back in the guidelines in 2016. However, in 2021, that evidence was upgraded from weak to moderate, which I guess in favour of their use. And in terms of where that came from, it was based on a large meta-analysis by a team led by Rygaard in 2018, and they looked at 22 randomized controlled trials comprising of just over 7,000 patients. Now, the reason why it sort of ended up being moderate evidence is because the outcome of the meta-analysis or the trial revealed that there was no statistically significant difference in short-term and long-term mortality in steroid treatment versus placebo. But it did demonstrate a statistically significant reduction in the duration of shock, mechanical ventilation days, and length of ICU stay. Although, actually, if you look at the forest plot of the trial, there's quite a large 95% confidence interval when it comes to the length of ICU stays. That's sort of a little bit ropey. And actually, what they did advise is that the risk of complication in the steroid arm was better, and complications that they largely found was an increased risk of hyperglycemia. And as we know, hyperglycemia is bad because it increases your risk of things like critical illness, weakness. So weakness and hyperglycemia were noted as the significant complications of steroid use in these circumstances. Now, this year, a large meta-analysis by a Canadian group led by Peter et al. Investigated glucocorticoids again in sepsis and septic shock. So basically did the same thing again, looking at the most up-to-date evidence. And I looked into, again, 45 randomized control trials, again, with a combined patient base of 9,500 odd patients. So pretty big patient population. But what was really nice about this study is they also looked into the dose responsiveness in addition to the standard outcome measures that the previous analysis looked at. So things like length of ICU stay, ventilation days, and mortality. And actually, based on the most recent evidence, they were able to demonstrate a statistically significant improvement in short-term mortality. So an absolute risk reduction of 21%, and long-term mortality, so risk reduction in 1.9%. So compelling evidence, finally, of a reduction in mortality. And the reason why that's important is because for those of you who've been in and around ICU for long enough, you'll kind of see that a lot of the guys who have been around for a lot longer than me will say, regularly, oh, steroids, they go in and out of vogue, they go in and out of popularity, and we seem to be in a phase where steroids are particularly popular at the minute. Now, going back through all the evidence, there's never been any compelling evidence that actually they improve mortality. Because I mean, we always look at the short-term wins, which is sort of reducing our ventilated days and reducing our length of ICU stay. But actually, if that's not going to improve your overall mortality overall, then you've got to question whether it's worth doing, especially given the side effects that you can have with steroids. It did, however, show that there was no effect on the duration of intensive care stay. Now, what was really important that came out of this trial is, as I said, it looked into dose responsiveness, and they found that the mean effective dose of hydrocortisone was 260 milligrams. So if you see our prescribing practices, we normally advocate sort of 50 milligrams QDS or a maximum of 200 milligrams a day. What this trial is suggesting is that actually that might not be enough in order to have an effective dose. So that's going to be looked at in the next update to the surviving sepsis guidelines, and we may well see that the guidelines suggest the dose increase probably to 300 milligrams or 250 milligrams, just because it's easier to do with the hydrocortisone, in order to have peak responsiveness. Now, as I mentioned, steroids are associated with adverse features as well, and it noted a significantly higher risk of hyperglycemia, critical illness weakness, and hypernatremia as well, which again sort of makes sense. That's actually been mirrored by another meta-analysis which Zoe sent me this morning or yesterday, that looked again from this year, that's looked into adverse effects of steroids in community-acquired pneumonia, and that again notes that hyperglycemia is a particular risk. So tight glucose monitoring is really important. And I mean, we do it anyway, but it's even more important for these patients who have severe sepsis and who we're starting high-dose steroids on. Right. So the next thing that I just wanted to look into and go over is that this kind of notion of combined steroid therapy. So there's been some new evidence that's been looking towards the use of combined steroid therapy in septic shock. And as I mentioned, that involves replacing both glucocorticoids and mineralocorticoids. So in practice, that is giving hydrocortisone and fludrocortisone as combination therapy. Now, again, I had a chat to Dr. Bouch and Dr. Flint this morning in the office, and apparently they used to do that. But as I said, we've now got some more of an evidence base that's coming forward that may advocate for combination steroid therapy. Now, if we look at the physiological principles behind that, now we're traditionally taught in sort of physiology and from med school onwards that actually if you give enough glucocorticoid, it will have mineralocorticoid effect, and that's correct, right? But kind of going back to first principles, the actual physiological actions of steroids aren't really understood in sepsis. So if we look at what the disease process is in sepsis as a whole, it results, although it kind of, you get the sort of macrovascular complications, sort of drop in blood pressure and organ dysfunction. Actually, what you get, you also get quite significant molecular injury in sepsis as well. So it causes the breakdown of both epithelial and endothelial systems, and that damages capillary beds. So you get this massive inflammatory process. But we kind of assume that sepsis is just your body being overwhelmed with inflammation, but actually what your body does as a response to that is you get a contrasting anti-inflammatory response. So that leads to a condition of relative immune paresis, and this is where I didn't quite understand it or didn't quite fully have my head around it when it came to steroids, because I just thought we were damping down that inflammatory response, which was the aim of what we were trying to do. But actually, that's probably not the case, because your body is already immune paretic at that stage. So actually, there's thought that they have some sort of immunomodulatory pathway, and that's kind of why your body secretes so much steroid or endogenous steroid and cortisol when you have an inflammatory response as well. It's not necessarily as an anti-inflammatory pathway, it's an immune modulatory pathway. Now, again, if we think about sort of the macrovascular stuff, shock activates your juxtaglomerular apparatus and activates the RAS system. And we all know that the role of aldosterone in that is well established in terms of sodium retention and fluid retention. Now, in sepsis, there's been noted to be relative adrenal insufficiency. So you don't produce as much cortisol, you don't produce as much aldosterone. Yeah. Although we kind of think that giving high dose glucocorticoids theoretically should replace that mineralocorticoid activity, the evidence at the minute from lab studies and in vitro studies are showing that this may not necessarily be the case. So kind of drilling down into the minutiae of it, there's relative selectivity of mineralocorticoids for aldosterone alone, particularly in organ systems such as the kidney, where actually cortisol doesn't have, or exogenous cortisol doesn't have as much of an effect as we initially thought it did. Also, there's the concept of ligand and tissue-specific dichotomy within the mineralocorticoid receptor. So what that means is aldosterone will cause one effect, whilst cortisol will cause the opposite effect. So we may actually be achieving the opposite of what we're trying to by giving high dose cortisol effectively, exogenously, sort of as an effect that we're not necessarily expecting. And also aldosterone plays other roles in blood pressure management as well, in terms of platelet activation and vasoconstriction as well. So we're missing out on all of that by thinking that actually we're replacing that with just glucocorticoids alone. So in terms of what does this mean for us? So the evidence is showing that there are new insights as to whether giving both together improves mortality. But I think you need to be really careful when looking into the most recent evidence that's coming out. So there's a meta-analysis recently that's been published by Tijer et al., which has shown that there is a potential survival benefit with fludrocortisone and hydrocortisone versus hydrocortisone alone, with a placebo arm as a reference. And it showed that the relative risk of mortality in hydrocortisone plus fludrocortisone is lower than in hydrocortisone alone. And this phrase, with a high probability of superiority, is important, and I'll tell you why that's important in a minute. So although that all sounds really exciting and we get to look back at our physiological principles and say, yeah, that might make sense, there are very few direct comparisons with combined therapy versus monotherapy alone. So fludrocortisone and hydrocortisone versus hydrocortisone alone. And this is the problem, really. So a lot of the data, if you drill down into this trial, was taken as secondary outcome measures from other trials, such as approaches which are looking into activated protein C and GURINT5, and I can't remember what that was looking at, but it wasn't looking at steroid therapy alone. So we need to be really careful how we interpret that. And this thing where I've written, reading the paper, it seems quite narrative rather than giving a clear picture. That's probably me slightly misunderstanding the statistics. But long story short, there are two different ways of interpreting statistics. One is a method called Bayesian, and the other method is a method called frequentist. Now, frequentist statistics aims to disprove the null hypothesis, which kind of makes more sense to us as medics, I feel, because it allows us to say, based on a predetermined set of criteria or predetermined power, this treatment is effective or not effective. The way in which Bayesian statistics works is it looks at the probability that one thing may be better than another. And because of that, it makes it sound a little bit wishy-washy, which is why you never really see it being used in many big research papers. And that's why I think it's probably you have to interpret it a little bit carefully, because to me, it sort of felt like they were trying to pull the wool over everyone's eyes by trying to bamboozle everyone with the stats. But actually, the simple fact of it is they've not done any direct comparisons, and it's certainly not enough for us to change our practice. What it does, however, give is a bit of a starting point for further trials to give us a direct comparison. So that's kind of where hopefully they're going to start looking in future, now that the kind of question, I'm hoping, of whether we give steroids or not is slightly put to bed by the most recent meta-analyses that are coming through. So that's the end of that. I appreciate it. It was very quick. Just make sure I'm not still sharing. I'm not still sharing, am I? No. So yeah, it was. I appreciate it was really quite quick sort of run through of everything, but I just think it's quite interesting. As I said, whenever you talk to our senior colleagues, they'll always be saying that, oh yeah, steroids are just in vogue and it will all go out the window again in another few years. But actually, I think we're now in a position where we're showing that, particularly in the context of severe sepsis, they are beneficial. And actually, the kind of combination therapy aspect of it is probably the next step in determining where we go in steroid therapy and sepsis. Cool. Does that make anything clearer? Less clear?
As unclear as it was before.
Yeah, and it sort of is, but and I get we kind of do it already, and it's kind of a bit like, well, duh, that's what we do. But I think, as I said, as long as I've been in ICU, which has been like nearly 10 years now, it's always been, yeah, we don't know if it works, but we give it anyway because it's a bit of a Hail Mary. But actually, there is some solid evidence coming through to suggest that it improves the long-term mortality, not just kind of our ICU parameters that we look at. So in the context of the fact that they aren't innocuous drugs, as I mentioned, they are associated with weakness, hypoglycemia, although the evidence doesn't suggest that it increases or the most recent evidence doesn't suggest that it increases your risk of GI bleeding. That is still a potential risk of steroid therapy, and we know that. So, as I said, I think the important thing to come out of all of this is that we now have some evidence to suggest that it's useful. Again, the mean effective dose is higher than what we're giving at the moment. So it's whether the surviving sepsis guidelines will change to reflect that, which I suspect they probably will, because that's what they've referenced as what's advising their practice at the minute in their most recent kind of releases. So that might be a place that we look at in terms of changing our practice. In terms of combined steroid therapy, I think what's important is we've now got a physiological basis for it. So it's just trying to see if future studies show that there is any evidence of benefit.
Do you think we should try fluticasone in the really septic?
So the problem is, again, we used to do that, and I don't necessarily think it's going to cause that many more issues than just giving hydrocort alone. But personally, I think we need to be careful doing anything without a solid evidence base behind it, particularly when you've got studies that show that actually just giving more hydrocortisone improves outcome. So I'd have thought that probably would be a better starting point to begin with than to start adding in other drugs without any evidence base behind it. But as I said, what's quite nice is from the studies and from the lab studies, they've shown that actually just giving more cortisol doesn't necessarily solve the problem. You do probably need mineralocorticoid effect, because as I said, with the ligand specific dichotomy, you may actually be achieving the opposite of what you want to in certain organ systems. So as I said, it's something that would be interesting to look out for in future.
Anish, I have a question for you.
Yeah.
In these studies, did they compare the endogenous cortisol level?
No, so again, they didn't look at endogenous cortisol levels either, and a lot of them were versus placebo. So as I said, theoretically, if you're giving a versus placebo, you technically are against endogenous cortisol because you're not giving anything. But as I said, they've not looked at overall endogenous cortisol levels in sepsis and what the overall rise in your cortisol level is once you give exogenous cortisol or hydrocortisone. But as I said, the simple fact that you're seeing a mortality benefit, and actually the mean dose that has been picked up in the most recent meta-analysis is greater than the dose that we're currently giving, it suggests that it probably does need some replacement. I guess the new question is whether actually we replace both gluco and mineralo, or whether we just give more glucocorticoids and hope that it has that effect. And again, that's probably where the research is going to come out from now.
Right. To my understanding, this steroid is beneficial in those cohorts of patients whose endogenous response is not that good compared to some cohorts.
Yeah, so there was, sorry. There was a question about responders and non-responders in one of the studies that was built into the meta-analysis. So it's patients that responded to, I can't remember the ins and outs of it, but basically that study alone fed into the overall meta-analysis this year. So that was part of it, but I must say I can't remember the ins and outs of it.
If I remember correctly, that was one of the studies post the initial river study, wasn't it?
Yeah.
Where the subgroup that benefited from glucocorticoids were the ones.
Yeah, they were the responders, and the ones that didn't. Yeah.
But then I don't think anyone could replicate those results.
So I think what eventually happened is they ended up showing a mortality benefit in the non-responders, in the responders, but not in the non-responders, which kind of makes sense, right?
But then you're going into subgroups of subgroups.
Yeah, but then you're going into subgroups of subgroups, and I think, to be perfectly honest with you, the fact that you can give someone 300 milligrams of hydrocortisone nearly and it improves their mortality probably suggests that your endogenous isn't really good enough, whether you're a responder or a non-responder.
Yeah. And since those studies, it looks like we stopped measuring it.
Yeah. But again, as I said, I would a learning point that I got from looking at all of this was I got really nerdy about the stats. And I had a really I had a really Dr. Scott conversation with Dr. Scott about statistics, and it is, as I said, it is really interesting how when you get into these big studies, how they try and bend the stats in order to prove a point that they're trying to show. So like I said, this thing about hydrocortisone and fludrocortisone, actually, if you look at the study itself, a lot of these things are looking at a lot of these things are looking at versus placebo, and we've already proven in studies going back yonks that actually there probably is some benefit from giving hydrocortisone. So if you're doing it versus placebo, which is effectively saline in a lot of the cases, then obviously you're going to see a survival benefit. So that's why you've got to be really careful looking at how they've done the statistics, and because I feel like because they knew that they chose to go with Bayesian methods to analyze it, to say, oh yeah, there is kind of like a good possibility that this might be better, rather than saying based on a predetermined cutoff this is better.
Yeah.
Cool. Any other questions?
Alex, you mentioned in the teaching the other day about moving towards steroids in CAP as well.
Yeah.
So presumably then that's not going to be, so because this is for specifically for septic shock, that's going to be a lower threshold to introduce steroids.
Yeah, I mean, it probably is. And actually, there's some papers that have come out this year which are showing that it reduces the risk of long-term ventilation, reduces the risk of ARDS, and reduces the risk of shock if you give patients with community-acquired pneumonia steroids. And as you said, it probably does need to be a bit of a balance in terms of if someone comes in septic, then they'll get it. I need to have a proper look at the CAP papers, to be honest, because I just sort of mainly focused on severe sepsis. But I think a few of the papers do note a better timing of giving steroids in community-acquired pneumonia. So that may fiddle the numbers a little bit, but this is specific for all forms of sepsis. And as I said, to be honest, at the Royal, we generally tend to see more abdominal sepsis. So it's quite nice to have a proper framework against which we can work.
There are lots of meta-analysis on the CAP patients, and those quarter patients who are severe CAP, they are level as severe CAP. There is the corticosteroid or steroids does benefit these patients.
Yeah, it makes, and it's based on, and I can't remember which criteria it was based on, but there definitely is a benefit in giving steroids to patients who have been defined as having severe community-acquired pneumonia, in terms of length of ventilation, risk of ARDS, and risk of shock. But
and
as I said,
bronchiectasis risk is also reduced on those patients.
Yeah.
The risk of bronchiectasis post pneumonia.
Yeah, yeah. But as I said, this is I've sort of mainly looked into sepsis as an umbrella, just because, as I said, I think the whole bit with hydrocort and fludrocortisone is one, quite interesting in terms of the physiology, but also as Dr. Flint just walks in, they were discussing in the office this morning, like, it goes in and out of fashion. It's something they were doing ages ago and then stopped doing, and then we might start doing it again. But I guess that's the point of having evidence that evolves, right?
Yeah.